Yes, Rameshji or Salman sir, we can start.
Yeah, yes. Sir, Salman sir, you can start now. And
So good evening to everyone. On behalf of Tamil Nadu Orthopedic Association, I welcome you all to the 31st TNOA PG teaching program. Today's topic is workman ischemic contracture. It's on part of a short case series. So today's speaker and the moderator are our TNOA office bearers. So speaker is Dr. Terrence Jerome. He is a chief consultant at Department of Orthopedics and Hand Reconstructive Microsurgery, Olympia Hospital, TRICHY. Dr. Terrence is our TNOA website coordinator and also mobile app coordinator. So today's moderator is Dr. G Ramesh Prabhu. He is our executive committee member. He is a senior assistant professor at Department of Orthopedics, Government KAPV Viswanathan Medical College, Trichy, and also in MGM Hospital, Trichapalli. So with this short note, I over to moderator, Dr. G Ramesh Prabhu. Please, sir.
Thank you, Dr. Saravanan sir, for your kind words. Good evening, one and all. I welcome all the postgraduate who joined here. First of all, I want to thank Tamil Nadu Orthopedic Association for giving me this wonderful opportunity for moderating today's sessions. Today, we have one of the most important topic or clinical examination of short case, workman ischemic contracture, very commonly kept in exam. Today, we have an eminent faculty, Dr. Terrence Jerome. More than faculty, he is one of the fantastic hand surgeon and brachial flex surgeon in India. He is a consultant and head of the Department of Orthopedics, Hand and Reconstructive Microsurgery, Olympia Hospital and Research Center, Trichy. He is editor-in-chief, Journal of Hand and Microsurgery. He was an ASS International Fellow in 2019. He got European Diploma in Hand Surgery. He has 62 publications still now, more than 200 paper presentation and 60 invited guest lecture at various national and international platform. He had the gold medal for best paper at IOCON 2016. In 2019 and last year, he got two consecutive years, two gold medal in TNOA conference for his excellent research work. He is one of the scientific and postgraduate PG teaching committee member of IOA and TNOA. He was the convener of Indo-Japan Hand Meet 2019. He is the admin of TNOA mobile app and website and immediate executive member of TNOA. This year, he received honorary FRCS from Glasgow. I think he is the youngest surgeon received this honorary FRCS in Tamil Nadu. More than that, he is my classmate and close friend. On behalf of all of you, I welcome Dr. Terrence. Welcome, Dr. Terrence. Over to Dr. Terrence.
Thank you, Dr. Ramesh, for your kind words and appreciation and introduction. Really, I'm grateful for your humbleness. Thank you, Tamil Nadu Orthopedic Association, the President and Secretary, Professor Tanapan, and the entire scientific committee who has given me the opportunity to talk about the basic and very important topic, the workman ischemic contracture, obviously, which will be an exam short case whenever you go for examination. Thank you, the Olympic, who has been the sponsor for this program, and the other delegates who have been here. So far, we have 33 candidates, delegates who have been here online to have discussion about this workman ischemic contracture. Well, actually, when I was discussing with Dr. Ramesh, I said, since he is one of the examiner for ongoing MS postgraduates, I thought this will be a platform for a one-on-one discussion rather than being no speech, giving a monotony speech. There is a common words you say when you speak, a few listen, but when you share, everybody listens. So this is one important aspect I like to have among the this case presentation. So I always like to have interactions with the postgraduates, because if you ask why and what and how, then only there's a aspect of learning many things rather than going monotonous and then getting things without analyzing in its scientific and rational way. So post all your questions in between, and then we can have a lot of discussions. Rather, I'll keep my presentation very short. We'll have a lot of discussion on what examiner exactly want to know from you. Most of the examiners are very particular in one aspect, like if you are a postgraduate or if you have become a consultant for a period of time, how safe is the patient to you? This is one aspect every consultant who becomes examiner thinks. Even I, if I am allowed to be an examiner, I always think that how safe is this postgraduate when he becomes a consultant. So meaning to say that what are the essentials you need to diagnose during a workman ischemic contracture, and what are things you need to suggest to the patient whom had come for a consultation or who have come for the surgery. So this short introduction, this workman ischemic contracture is a must, is a mandatory case. Wherever you go, there will be a case of any ischemic contracture. During our postgraduate time and during examination time, there are a lot of patients kept for short case, especially during our time where there are rampant local, we say non-physicians, we say quack and other non-practitioners who treat these injuries and then causing severe compression compartment syndrome and then developing all contractures, which are not amenable to treatment when they present. They always present with ischemic contraction. So we will directly go to the presentation.
Yes.
Yeah, we all know that the name which is being given to this ischemic contracture is because of Richard von Workman, who actually had found this problem in 1826. And then later, he exactly pointed out the problem in 1881 because of ischemic contractures in the forearm. The most common etiology which we come across is diphyseal forearm fractures, around 50 to 22%, displaced supracondylar fractures, which accounts for 1/3 of all fractures. And moreover, of the late, there is high emergence of applying a tight bandage or a local oil native or a tight bandage, whichever sort you come across in their practice, where a non-allopathic doctor or a quack who applies an oil bandage and then causing compartment syndrome. And of the late, the high energy injury is the only reason which causes the compartment syndrome. It just most of the injuries which we come across are because of high energy injuries. In a nutshell, what are things we need to understand before going to clinic examination? The pathophysiology behind workman ischemic contractions is that there is definitely an artery injury or spasm, which initially, when there is prolonged, it can also be. Am I audible with this?
Yes, yes.
Yeah.
Yes, yes, Mr. Ramesh.
Yeah, okay.
Audible, audible.
Yeah, just hold on. So in what happens in the initial phases, there is a prolonged and severe incomplete arterial injury. With this, there is a lack of blood supply, the arterial blood supply to the forearm, especially when you have a high energy injury or a spasm or direct injury to the artery. So it causes venostasis. Again, it causes a vicious cycle of causing less blood supply to the muscles and also to the nerve, causing ischemia. Muscles and nerves cannot withstand ischemia. So then, over a period of time, say every nerves and muscle can only withstand a certain amount of ischemia. So with that duration of time, they become necrosis, contracture, fibrosis, and then they develop the contraction. This is a sequelae, which everybody should understand what is the pathophysiology behind the workman ischemic contraction. So what exactly is happening and why is there a contracture? We all know that the most common question an examiner asks in the short case is that how long a muscle can withstand ischemia. So roughly the scientific reasoning is around 4 hours. So when the muscle is beyond 4 hours of ischemia, they all go into irreversible muscle damage. That's why mostly we always take off the tunicate around 2 hours of time. That's half the time of ischemia where the muscle may not go into irreversible permanent damage. So once it goes into ischemia, they form an elliptical shaped fibroblast. And those fibroblasts are the one which later forms contracture. And those are the one which always involves the nerve because of the ischemia. They develop associated sensory loss and contracture in the hand. This is where we call as the infarcted, the ellipsoid shaped infarct in the deeper compartment. So the most other common question when any examiner watches a patient who has a workman ischemic contraction is that they'll start with the definition. Define workman ischemic contraction. So the end result of the prolonged ischemia is always associated with irreversible tissue necrosis and a spectrum of presentation. So to make a warm-up, before you have a 100-meter run or wherever you run, you need to have a warm-up. This is just a warm-up of what we are going to discuss and what is the topic today, which we'll have as a short case in the exam. So with this short introduction, we are going to discuss about the clinical picture, how it's going to present, what are the things the examiner asks or expects you from the general examination, local examination, how are you going to come to a diagnosis, what are the other differential diagnoses, and then the treatment aspect. So these are the things which has to run quickly, say in a short span of 5 to 10 minutes, because all those is the time which is given in a short case when you have a case like workman ischemic contraction. How is the clinical picture? What are the relevant positive history finding? How is it going to present to us? What are the examination, specific signs which the examiner obviously want to know, and the diagnosis, and then differential diagnosis. Most of the time, many surgeons, like being examiners, they will always prefer to have more on the clinical picture and how we arrive to diagnosis. If you cross all those things, and the treatment is always, is favoring always towards the candidate have done successful. So you mean to say that you've done excellent during all these initial presentation, clinical finding, and then differential diagnosis. Most of the examiners are very happy. Then they come up with the options of treatment options. What are you going to do? How are you going to do? You need to say that they will lack more conversation, they'll enjoy the conversation with you because you have been excellent in doing all these clinical examinations. So all the examiners want to know, how are you going to clinically examine, how are you going to differentiate it, and then how is going to be treatment. So always have the basic concept. How are you going to deal with the long case? Similarly, you're going to deal with a short case. But then in a short span of time, in a nutshell, you need not go in a brief of entire, presenting illness, the history of treatment, past history, associated other histories. So all these things have been put in a very short cell. So I've seen many people, many of the postgraduates, they knew the diagnosis, they knew the answer, but then the way the presenting is always very, very important. It is always very, always triggers us to say the diagnosis immediately, and thinking that we are, the examiners will be very happy. That is not the scenario. So always play safer. Have a diagnosis at the end. Get the examiner to be very convinced that you've properly done the examination, and you also raised that a lot of things, should be considered before, coming to the present, diagnosis and the treatment. So with this, we'll have the picture. So how was the clinical picture where you can expect a open ischemic contraction? So this will be the presentation. You'll have a short case, a girl or a boy. This is one example because I have maintained this example so that you will not have any problem, in understanding the scenario. This is one girl who came to us with a, deformity in this. So you start with the inspection. Always inspect both upper limb. Keeping both upper limb together, you'll always feel the problem which is most significant, and always specify the most significant deformities starting with inspection. The inspection always starts with attitude. So this is what you come across, a short history. And the clinical examination starts always with inspection, palpation, and then you come across the specific motor examination, sensory examination, range of movement, and then a provisional diagnosis. This is how a clinical presentation goes. So the presentation goes like this. So I'm thinking I'm a postgraduate. So this is how I'll present. Let's say a 11-year-old girl who had a fall on the outstretched hand. She was treated, she was injured at the time of presentation. She had pain and swelling in the forearm, for which she had a native local oil bandage. The bandage was so tight where she had severe pain. Subsequently, the parents and the child was so painful, severe pain, made them to remove the bandage, and then they started finding loss of sensation in a particular portion of the hand, and always they found the weak movement in the hand and also in the forearm. So this will be the presentation, a short history. And always, mechanism of injury is more important because most of us, when we are as a postgraduate, we had fall of the outstretched hand as a common reason for this presentation. But now things have changed. Of the late, the most common involved mechanism is the rotor of accidents, high energy injuries. So if a patient had a high energy injury, mentioned that. This is a girl who had an injury when they are traveling in a car or a bike, sustained a crush injury, and then the child had subsequently developed pain, swelling, and loss of sensation, or maybe had a fracture which was diagnosed by the treating doctor, and then he was put on a above elbow slab or POP cast, and subsequently the child had developed this deformity. So the most common history is, in a short nutshell, either fall on the outstretched hand, how they've been treated either by the conservative, by the treating doctor, or they have been treated by allopathic people where they have developed this deformity. This short history will always convince the exam, okay, they are now focused towards the diagnosis. What is the problem which has caused a compartment syndrome? And the sequel of compartment syndrome is the workman syndrome contraction. More people wanted to know about the pattern of symptoms. If you could easily grasp them, pain is the most common symptom. And they'll examine immediately come to other aspect. So is only the pain most common symptom you will appreciate? Book says that there are 5 P's which you should have in mind: pain, pulselessness, pallor, paralysis, and paresthesia. So these are the 5 P's which always the examiner wants to ask. What are the 5 P's which are more commonly involved in the presentation of a workman ischemic contraction? So this 5 P's you should always remember in that. Now the 5 P's are being moved for children. We cannot have the 5 P's for the children. Children are very, they cannot communicate, they cannot say what exactly they have. So for the children, they have put as 3A: anxious, agitation, and analgesia. Child are always anxious. They're either scared of the doctors or scared of the parents, because they might have scolded. Agitation is because of the pain. They are beyond, the expression, and they are absolutely restless because of the pain associated with the compartment syndrome, because it is a very, very exsanguinating, very, very deep, severe pain. The other is the increasing need of analgesia. The history goes like this. Sir, he had a fall. We went to the local doctor. The child was given some analgesic. Child did not, stop crying. Again, we have to give more analgesic. Even then, it did not cry. So increasing need of analgesia, 3A, is also more important history when dealing with the children with history of compartment syndrome. These are the more thing which favors. Other thing is that the pain is not supposed to end. Pain is always severe. So that history is very specific. So severe pain, which is worsening gradually, means that the child is developing some sort of ischemia to the muscle, some sort of ischemia to the nerve, and subsequently it develops the contraction. So quick positive details. Maybe these are the information which you should have, because there may be circumstances where the patient may have had a head injury, unconscious, could have sustained a forearm fracture or a supracondylar fracture where unnoticed. They could have also had a brachial artery injury. So a head injury patients unconscious might have developed a compartment syndrome. So quick history of these possibilities must be taken care. Surgery, most of the child don't have any surgery, because all these are established deformities of Volkmann ischemic contraction. So these patients will not have any positive history. A relevant positive history and should be mentioned. Why drug history? One of the contraindication for surgery in these patients are patients who are on anticoagulant or patients who are bleeding coagulopathy. So these are the things we should immediately come to you, whether these patients had this positive finding. So any bleeding diathesis, coagulopathy, those histories should be sorted out. Any surgery should be sorted out. And the other positive history is that any animal bite or venomous bite should also be quickly sorted out. So this will be the clinical picture of a girl. So while you have this picture, always have an inspection. So divide this into many aspects. Inspection, what is the positive relevant finding in the inspection, palpation, and then special examination, general motor examination, sensory examination, other test. So in a nutshell, this is a child who had this presentation to us. The examiner's most favorite question is, whenever they see a patient, they'll ask, what is a Volkmann sign? Because that is a mandatory question for all examiners to ask. Volkmann ischemic sign is nothing but, so this patient, they have contracture in the, in the muscles, long flexors. Long flexors are the FDS and FDP. Long flexors are the FDS and FDP because they start from the supracondylar area, forearm, and then passes the wrist to the fingers. So they are long flexors. Short flexors are the flexors which are in the start from the wrist and they end up in the fingers. Meaning to say that FDS and FDP are the long flexors. So the commonly involved muscles are the long flexors. So what happens? They get contracted because of the infarct, ischemia, necrosis. They get contracted. So when they get contracted, they flex both the joints. So FDS, it flexes the PIP joint. FDP, it flexes the DIP joint. So this is for the 4 fingers. Similarly for the thumb, FPL flexes the IP joint. FPB, the MCP joint. So these are the 2 important muscles in the thumb and also in the fingers, which you need to understand before going to the contraction. So once they get contracted, what happens is they always pull the fingers because of the contraction. They always pull the fingers. So what happens is in Volkmann ischemic sign, when you passively extend, because of the contracture, the contracture gets relaxed. So fingers become straight, something like this. And when you dorsiflex, the fingers are stretched. The long flexors cannot extend, cannot have the elasticity because they lost because of the contracture. So it always makes the finger to flex more. You cannot extend this finger. Meaning to say that the length of the flexors have a constant length. It cannot, like elasticity of the flexor tendon, it cannot flex, cannot extend. So it's a constant length phenomenon. This flexor tendon have constant, they have only fixed length. They have only contraction because of it. It has only fixed length. It cannot extend, it cannot flex. So when you flex the wrist, the fingers can go into extension because the length remains the same. When you extend the wrist, the contraction becomes more prominent, causing more contraction. This sign is more important because they will definitely ask in the exam. So the general physical examinations that you have seen in the last slide. So this is the attitude. So you can start, memorizing this when you have an attitude. So child, as I say, 11-year-old girl, on inspecting the right upper limb, the shoulder is adducted, the elbow, look at the elbow. So elbow is flexed, the elbow is flexed. Find the forearm. The forearm is in the pronated condition. Forearm is pronated, wrist is flexed, and the fingers are extended at the interphalangeal joints. This is more important. So more specific. So by listening to this, the examiner are in a understanding that, okay, this child has a contracture in the elbow, contracture in the pronation muscle because the pronators are involved in this. There's a contraction in the wrist, meaning to say that the long flexors are contracted and the wrist is in the attitude of flexion. The fingers are in the attitude of extension. It means that there is definitely a contracture in the compartment, which always involves the forearm. Can be a superficial or can be a deep. So this is what a clinical examination. So start with the inspection. The inspection is this. In addition to that, look about the skin. So you can see all scars. So you can say that there is a unsightly scar seen in the, this is called as the anterior aspect or the olar aspect of the forearm, and this is the extensor aspect or the dorsal aspect. So there is an unsightly scar seen in the, proximal portion of the forearm in the olar aspect. Look for any of the sinuses because the infection might also have costic compartment syndrome. So there is no scar, sinuses, or any swelling. And the other thing is that there is an apparent shortening. We can directly see that there's shortening because I have compared both the upper limb on inspection. You can probably say on the safer side, there is an apparent shortening of the right upper limb, which I have found on the inspection. And most common thing is, which is, staring at the eye, is the wasting. So the forearm compartment is a huge bulk in the proximal forearm. Distalmost are the tendons. So you need to be more specific, which is more, obvious in this case. There's a marked wasting of the forearm muscles in the in this girl. So to summarize, on inspection, the attitude, the muscle wasting, the skin, whether it is stretched, shiny, or any scars or sinus. Look for trophic ulcers because these patients may also have some median nerve or sensory nerve involvement. So they may have the wound because of atrophic, because of lack of proper sensation to the fingers. So look for trophic ulcers in the fingertips because without unknowingly they could have tried and taking hot vessels, or they could have had a prick because of sharp instruments where they handle because of loss of sensation. So these are the most important things we should understand when you have in the inspection. So inspection is very simple. The deformity, wasting, associated skin, other conditions. So this is what I'm summarized to this. There may be certain conditions also where can be associated with surgical scars for patients who might have had fractures forearm being fixed or for any other injuries they have fixed it. So this is an aspect of inspection. So palpation, start doing palpation. Watch this video. So the patient has an elbow which cannot be extended to a certain degree, which you need to measure through a goniometer. Goniometer is mandatory for all hand injury patients, especially if you're going to measure the range of movement. So look at the elbow. So this is a child where the elbow flexion is complete to say around 120 degree, and then extension is up to say it's around 60 to 70 degrees of extension. So we need to say that this patient has a flexion contraction from 60 to 70 degree to 120 degree. So this is for your knowledge. So do not commit unless you measure it. So in palpation, you should find the elbow, and is there any bony block on the extensor aspect which is causing the extension deficit, or palpate around the elbow to have any thickening or the bone which is have malunion features. And in addition to that, feel for the forearm muscles. The forearm muscles are having a normal tenor and the vigor of a muscle on the normal side, but these patients will have a fibrous muscle. So obviously you can see that the wasting can be appreciated in the palpation. In addition to that, you may not have warmth or tender patients because they're established compartment syndrome with all this contraction. So to have a safer play, always start with all palpation, always start with warmth. Examiner might ask, did you really have any significance of warmth in these patients who are a contracture? You might be playing very safe. You might be saying that any additional associated infection could have caused the compartment, or associated soft tissue infection or a bone infection, I expect could have been there for long duration. So these are the things which you need to be playing very safe. So to have a palpation, always have this finding of not warm, not tender, and look for sweating, because most of the patients are very anxious, or they may also have a sympathetic overactivity, where this is also an addition, because you have all those clinical and relevant points are going to convince the examiner that you have properly examined this patient. Nobody is going to fail you. We have done a good clinical examination. Diagnosis and treatment is a different aspect. So since this patient had a scar, you always need to examine the scar. Whether the scar is superficial, adherent to the underlying structure. So these all have significance, because underlying scar adherent to the bone always signifies a previous history or a previous episode of infection, osteomyelitis, having a sinus healed. So these are the concepts which need to be emphasized during a palpation. To complete that, is there any nodules or swelling? These things has to be properly described in the palpation. Next comes the most common thing. Deformity is always very essential to be clarified. So what deformity is there? So what are we expecting? So to keep very simple and precise, the most common muscles which are involved are the volar compartment muscles of the forearm. So what are the muscles are there? They are pronator muscles, long flexors. These are two muscles which are there. So these two muscles which will cause the contraction of the flex fingers, and in addition to that, they'll have the pronation contraction. Because the pronator muscle is involved, they'll have pronator contraction. So the attitude will be something like pronator. And in addition to that, the fingers are flexed because of the contraction of the long flexor. So the attitude will be like flexion of the wrist and the fingers, and in the pronation. So this is the common attitude. So you need to be more specific. You should be focusing that, okay, this is deformity because of the ischemic contraction. This is there, so this will be there. So how much deformity is there? Whether the deformity is passively correctable or not correctable. Why? Because this has significance. All passively corrected deformity means that the deformity is I have a few questions. Probably we can have the questions at the end. Yeah, I've got a question, so practically I can discuss about all these things. So why the flexor compartment is more commonly involved? So very valid question. Why it is involved? Because the flexor compartment are the compartment where it has two volar, deep and superficial compartment. Extensor have two compartments, the common extensor and the mobile vada Henry. The common reason why it is involved is the first and foremost muscles to involve are the volar compartment, because the blood supply is such a way it passes from the brachial artery, divides into ulnar and the radial artery. It can be ischemia subsequent causing compartment syndrome, or it can be a direct injury to the forearm muscles causing localized ischemia to the muscle, localized ischemia to the nerves. These are the muscles which are most commonly involved because of the location to ischemia, either to the vascular injury or to the direct injury. So that's the reason the compartment muscles are involved in the forearm aspect. So most commonly involved forearm muscles are the deeper muscles, which I'll come through the discussion and also in the treatment aspect. So far this is one. The other question is, how do you differentiate a joint deafness from a contraction? Very good question. The contractions are, it can be I'll tell you. See, this patient has a contraction. My hand has a contraction. Joint stiffness means that irrespective of any movement, the joint will not move. Just for it is simple examination, simple, to be very precise. Say, for example, to understand this, we need to understand this is a synergy. Synergy is you flex the wrist, the fingers go into extension, the thumb goes into abduction. When you extend the wrist, all the fingers go into flexion, the thumb go into adduction and partial abduction. So if you have a contracture, say for example, if you have a contracture in the muscle, will the fingers stop moving? Fingers will move because there is no stiffness in the joint. You can passively move the fingers at the joints, meaning to say that there is no joint stiffness. Okay. If you have a contracture in the polar compartment muscles, the muscles may be tight, may not allow you to extend. But once you relax, making that the contracture will not allow you to flex, you can passively flex and extend the wrist. I'll show you a few of the examples. Then you understand what is stiffness. Joint stiffness, joint will not move. Contracture stiffness, all the joints will move. The muscle is the main reason for the contracture in the forearm compartment. In the fingers, there may be associated ligaments which may be contraction, either on the volar side, the volar plate, on the dorsal side, the central slip. Beyond that, there will be a passive movement, which is possible in contracture stiffness. So with this, we will go to the other aspect. So the other aspect is the motor examination, because you need to know what are the muscles are functioning and what are the muscles are not functioning. How are you going to make this girl a functioning hand? We do not want to have a normal upper limb. We want to have a functioning upper limb. So watch this child movement. So the child, so this is the, which I am mentioning. So this is the flexor tendon, which is moving here. And there is a contracture which is happening here. Because of this contracture, it is being always pulled. This flexor muscles are always pulled. So because of this pull, the wrist is in the contraction position. You can passively extend to a certain limit where the contraction becomes very tight and will not allow you to extend the wrist. So because of this, the fingers can only extend. The fingers can only extend at the IP joint. This is the proximal interphalangeal joint. This is the distal interphalangeal joint. We call it IP joint. So the MCP joint flex is in the attitude of extension. The fingers are only extended here. Look at the thumb. Thumb is always adducted. Thumb is always adducted, and a flickering of abduction is possible. So this is the deformity which we need to assess with active movement of the patient. In addition to that, you should always look for this is the normal picture how to examine a median nerve. The FDS is supplied by the median nerve. So this is the way how you examine the FDS muscle. This is the way how to examine the FPL, because these are the motor functions which are supplied or innervated by the median nerve. And this is the way you differentiate by the action of FDP, the flexor digitorum profundus, which flexes the DIP joint. DIP joint are the distal interphalangeal joint. This is the proximal interphalangeal joint. In the finger, we have metacarpal phalangeal joint, the proximal interphalangeal joint, and the distal interphalangeal joint. Thumb has two joints, the MCP, metacarpal, and IP, the interphalangeal joint. So only this is the basic difference between the joints and the movements. So in addition to the finger movement, you should always look for the other pronation, supination. So obviously, they have pronator contraction. They cannot have supination, meaning to say that the pronation is so contracted and fibrosed, it will not allow the supinator to work. So any contraction, the opposite movement is not possible. Why? Because the muscle is contraction and is fixed in that position. So you cannot have any movement beyond that. The other favorite question is that most of the examiners, they want to know what is Volkmann angle. So these are the common questions which we face when you have a short case or even a long case. The Volkmann ischemic angle is something like, you flex the, as I was mentioning, when you have consider the previous girl, had a contracture at a constant length, constant flexor length, cannot extend, cannot have its elasticity, it cannot relax or it cannot contract when the wrist is flexed or extended. So when you make more wrist flexion, all the fingers go into extension. If you want to measure the contraction angle, because the workman ischemic angle, and you need to extend like this. You need to extend the fingers together to a limit where the fingers cannot be extended. Fingers cannot be extended. Because this is tight, this will not allow the fingers to go into extended. So to an angle where the fingers start flexing, that is the angle with the neutral angle, and measure this angle. This angle is called as the workman angle, because this has very significance. This meaning to say that definitely these are the patients whom they need surgical intervention. What surgical intervention? Depending upon the contracture classification, which we'll go into discuss subsequent slides. So what? Okay, this is the angle. So you can measure the angle, saying that the angle in this workman ischemic angle in this patient is 45 degrees. What is the significance? Significance is that the flexor compartment muscles are contracted. It is not allowing the finger to extend, meaning to say that either you can release the muscle distally, or you can lengthen the tendon so that the fingers can be extended and the deformity can be passively corrected. So this is the idea. You should have an idea why and what is the reason. So surgical role is there depending upon the angle of workman angle, and what are the surgery you are going to do. This is surgery you are going to do, plan if this is the angle is there. The one question, how do you differentiate between the stiffness? So this is the one patient whom we had severe workman ischemic contraction. So probably you'll be having cases in the exam with this sort of presentation. So this is something where a classical presentation of a claw hand. See, the MCP, this is the MCP joint, which is hyperextended, and this is the proximal phalanx. This is the PIP joint. So there is a flexion at the PIP joint in all those fingers, hyperextension at the MCP joint, classical claw hand. How are they going to correct? They'll flex the wrist. While flexing the wrist, what happens? The deformity gets milder. Why? Because while flexing the wrist, you are passively relaxing the flexor muscles. Why the flexion here? Because of the constant pull of the flexor muscles, long flexor muscles. The long flexor muscles are, the FDS is supplied by the median nerve. So it always constantly tries to flex the MCP joint, the PIP joint. That's the reason PIP joint is flexed. Why there is no movement? Why there is the MCP joint goes into hyperextension? Because all the intraosseous muscles are supplied by the ulnar nerve. So ulnar nerve is which always causes the flexion of the MCP joint, extension of the IP joint. This is the function of the intraosseous muscle. Exception is the lumbricals. The lateral lumbricals, 1 and 2 lumbricals are supplied by the median nerve. That is the reason you have a claw hand like this. Anyway, the intraosseous are wasted, intraosseous are involved in the ulnar nerve. Why you have claw hand in these two fingers? Because these two fingers have the lumbrical muscles. The function of lumbrical muscle is also flexion of the MCP joint and extension of the IP joint. So they mask the deformity in these two fingers. They mask the deformity in these two fingers. That's why you have a claw hand like this. But the problem is all the 4 fingers are involved. All the intraosseous are involved. Why not significant in these two fingers? Because the lumbricals are supplied with median nerve. When you have combined median nerve and ulnar nerve, you will have classical claw hand deformity like this. So this is a child which with workman ischemic contraction, they're presenting with this deformity. The other significances I'll show in the other videos. So always measure the angle. There's one question, what's the difference between contraction and joint stiffness? You will not have a movement here. If the joint is stiff, you will not have any movement here. See, this patient has a movement of this, from this to this. This is the way you measure the wrist angle, how much is the wrist flexion contraction, how much is the wrist flexion possible, and how much the wrist extension possible, and how much the MCP joint flexion. So all these are the methods how will you measure the range of movement at the individual joints. So in a joint stiffness, there won't be any movement. But in contraction, there will be movement once you lessen the contraction, either by flexing the wrist or extending the wrist in terms of contractions. So other way of finding whether this patient, how the deformity can be corrected. So I was mentioning the previous child that the same severely contracted girl, he had a hyperextension at the MCP joint and flexion at the IP joint. So how are you going to correct this? You're going to get back the interosseous muscle. How are you going to get back the interosseous muscle? By temporarily, you stabilize the MCP joint. When you stabilize the MCP joint, the patient can actively extend the IP joint and actively flex the fingers. Meaning to say that this interosseous muscle is more essential because all movements should have MCP flexion to have a good function, good catch, or good functioning of the flexor muscle. Without this, it's very impossible. There will always be a photo either in your orthopedic textbook or in Green's operating textbook. There will be a patient who will have a round ball here, cannot able to hold because the MCP cannot flex. For any movement, if you need to have a catch something like this, the MCP has to bend. Without MCP, it cannot hold it. There will be, it cannot have the grip, it cannot hold it. For any movement to have a grip, you need to have the MCP flex and then subsequently the flexion of the PIP and the IP joint. So that is more important. So why you are checking this? Because any surgery we need to do in these patients has to take care of MCP flexion. So all those surgery has to be done so that the MCP joint flexion improves. Subsequently, the other deformity gets correct. There are other special tests to diagnose associated median nerve and associated ulnar nerve injury. So how do you check for the median nerve? So always palpate the abductor muscles. Always palpate the abductor muscles by giving resistance to the proximal phalanx. Feel for the muscle. The abductor is the function of the median nerve. And off the lid, this is we call this a O test. I do not know how the name come for a O test, but the explanation behind this is the function of an anterior interosseous nerve, which is a final branch of the median nerve. So what happens is anterior interosseous nerve supplies the FDP, flexor digitorum profundus of index finger, and when there is any injury to the flexor digitorum profundus, in addition to the flexor pollicis longus, they will not have a O, rather they will have this hyperextension at the DIP joint because this flexion is lost by the lack of functioning of the flexor digitorum profundus, and you don't have the FPL, it's also supplied with the nerve. So the patient will have like this. So always ask the patient to make a O shape. It means that the median nerve is intact. Obviously, the anterior interosseous nerve is intact. In addition to that, these are the muscles which obviously on the dorsal side are the dorsal interosseous. So give resistance to the index finger and feel for the first dorsal interosseous here. Similarly, restriction to those fingers and then feel for the interosseous muscle. And the middle finger is the long axis. Based on the middle finger, you can either abduct the fingers or adduct the fingers. According to that, you have a mnemonic, that is palmar abduction and dorsal abduction, PAD and DAB. Palmar adduction, dorsal abduction. So these are the function of the interosseous is innervated by the ulnar nerve. The special test is the Fromenstein, which is classical of the ulnar nerve palsy, where instead of the adductor, instead of the thumb adductor pollicis, which is supplied by the ulnar nerve, when this is not functioning, the patient always uses the FPL, which partially acts as adductor to hold any object, especially a book. So now coming to the classification. So once you have a proper diagnosis, a clinical history, inspection, palpation, finding out the deformity, measuring the deformity contracture angle, measuring the range of movement, you need to focus, you need to put this patient towards such a deformity. What deformity, how much is the deformity the patient has? So to have a very, precise, about the workman ischemic contracture, way back, Holden is 1975 and 1979. He said there can be two type of contractures. One, say for example, if you have a brachiolateral injury here, subsequent to the brachiolateral injury, the patients develop compartment syndrome. That is one type. Other type is you have a direct force, high energy force, particularly to the muscle. So underlying muscles go in for compartment syndrome. So the two types of compartment syndrome. But why this is not being followed? Because they don't have any prognosis about which needs what treatment, what classification, what deformity needs what surgery. So then Suke, who had a wider analysis of the deformity, and he has divided into three category of class contractures: a mild, moderate, and a severe. What is mild? On the left, what you see is a mild. There's a contracture here, which is obviously established one. So how you diagnose a mild deformity? It can be only localized to a part of a muscle here, the deeper compartment muscle, or can only involve the FDP of a ring finger or long finger, so that these two fingers are contracted and no nerve finding. Sensation, functions are normal. They are classified as very mild deformity. It is very difficult for exam going students to have a mild deformity, because most of the deformities are either moderate or severe with established deformity. The moderate deformity are involvement of all the deeper muscles. There are two compartments in the volar aspect, superficial and the deep compartment. So keep it as simple. Superficial are muscles which involves the superficialis. We say that flexor, distal, or superficialis. So these are the one, they are in the superficial compartment. So they are involved in the superficial, when there's a superficial infarct. Deeper muscles are involved in the larger aspect of the contracture. So the deep muscles are your all FDPs, flexor distal profundus, and the flexor pollicis longus. They are lying deep, close to the bone. So those are the ones who are really first involved. So because of the involvement, you have severe contraction of the particular involved fingers. Say if the long finger is involved, the ring finger is involved, those are the ones who develop contractures. So deeper muscles are the FDP and FPL. Because of this, you have contraction in the fingers. Then come the superficial muscles. They are the flexor distal superficialis. And subsequently, because of this, you may also have associated finger involvement. The nerves, most commonly involved nerve is median nerve. There's one MC multiple choice questions. The option, the sequence of involvement of the nerve are median, ulnar, radial. So most commonly involved is the median nerve because of the location. The centralmost location of the in the forearm is the median nerve. So they are the one more commonly involved. The ulnar one are late involved. I don't say they're not involved, they're late involved. The more the duration of ischemia, longer duration of ischemia, even ulnar nerve is always involved, causing a severe deformity. So severe contraction is on the last bottom, where all the flexor compartment is involved. In addition to that, all the extensor compartment is also involved. And they have a severe varying neurologic deficit in addition to the hand deficit. The hand will always have two deficits. One is the intrinsic plus and the intrinsic minus. Intrinsic minus is nothing but your claw hand deformity, where hyperextension and flexion at the PIP joint, IP joints. Intrinsic plus is the flexion at the MCP joint and extension at the IP joint. We don't commonly see intrinsic plus deformity. What we commonly see is an ulnar involved intrinsic minus deformity. The other most important is always the examiner wanted to know how do you examine the sensation in this patient. Why sensation is most significant in this patient? Long duration of walking ischemic contractions, they have some sensory deficit. Our median is more involved than the ulnar nerve. So sensory examination is also an integral part of any hand examination, especially involving nerves or a compartment syndrome sequelae. So these are the essential parameters, essential tool of investigation one should carry before going to the examination. This is a locally made 2-point discrimination test. This is a piece of cotton. This is a cotton whip. This is called a Simmons-Wilstein monofilament. There are 2 number monofilament. This can also have from 1.6 to 6.5. You need not have that much amount of Simmons-Wilstein. At least 2 sizes is sufficient for you to do examination. So to make it very clear, this is the pattern of involvement of the median and the ulnar nerve. On the volar side, the entire volar aspect of half of the ring and the ulnar finger, the little finger is supplied by the ulnar nerve. On the radial side, 3.5 is supplied by the median nerve. On the extensor aspect, this is supplied by the ulnar nerve, and up to the PIP joint supplied by the radial nerve, and the tip of the middle phalanx and the distal phalanx of index ring, middle and the half of the rings of the median. So this is more important. So whenever you have any patients or whenever you have any neurology examination, have this in mind. They may ask you what is the autonomous zone of the ulnar nerve, or the autonomous supply of the median nerve. Very favorite question for an examiner. The other thing is that how will you, what is the significance of this sensory examination with this 2-point discrimination test? Because these are the one which detects how is the recovery of the sensory aspect of any particular nerve which is involved. How can you localize, pinpoint, or a 2-point discrimination, which is very significant of the nerve recovery pattern. This is very more important during the examination. So in a short case, how will you say a diagnosis? So we have all come across a pattern of diagnosis, clinic examination, and then we need to come to a diagnosis. So how are you going to say diagnosis? Say, this is a 11-year-old girl, a case of mild or moderate or severe workman ischemic contracture involving the right upper limb or a left upper limb with a flexion pronation contracture of the forearm, flexion contracture of the wrist, an intrinsic minus or intrinsic plus deformity with a median or ulnar nerve deficit with a shortening. So this true shortening you have to measure when you do a motor examination or when you do a palpation. Exact measurement on the involved side and the exact measurement on the opposite side. So these two will give the difference between shortening. So with this centimeter of shortening. But this is a way where you present a diagnosis of a short case. So when you have all these ladder of examination, this diagnosis will fetch you or will convince the examiner that you have done a proper job of diagnosing a workman ischemic contracture. There may be some examiners, either lack of time or just want to pass through quickly. So immediately if they see a patient like this, they'll ask you what is the diagnosis. So more specific, put everything there, right from your history and your relevant positive clinical findings and a favorable diagnosis. So always have this diagnosis, presenting to the examiner whenever they have, whenever they do not want to listen to history or the examination or because short case is always short case. It all depends upon the examiner's mood. There are examiners who really wanted to have this short case as a long case. They'll have a discussion of entire, sequelae of compartment syndrome, classification, treatment aspect. So this is a diagnosis. More than that, they can also have what is the differential diagnosis. So what are differential diagnosis of this patient? Obviously, there's one aspect called as pseudo workman ischemic contracture. What is pseudo ischemic contracture? Pseudo ischemic contractures are contractures or entrapment of particular single muscle. Say suppose only the FDP of the long finger is involved, that finger only goes into flexion. The other fingers are normal. Or FPL, the flexor pollicis longus, could have got attached to a distal radius fracture, fixation, or plate. It could have got only contracted. The fingers are normal. In addition to that, more specific is that how you differentiate between a pseudo workman and a workman. Sensation is not involved. Sensory loss is not involved. A nerve are not involved in pseudo workman interaction. So in workman ischemic contraction, there is a nerve involvement. Ischemia to the nerve, ischemia to the muscle causes the contraction. But in pseudo workman ischemic contraction, only the muscle gets ischemic and they have developed contracture. There is no involvement of the nerve, either sensory or motor. So that's one different point. The other aspect is that adhesions. So most commonly is that any distal radius fracture or a forearm plate fixation might have caused a contraction or adhesions because of the long flexors, a particular flexor, which are adherent to the underlying fracture site, causing some adhesions or contractions. Those can be particularly, differentiated when you have that specific function elicited on examination. Scarring because of osteomyelitis or because of healing infection can also cause a localized contracture, which is very vital to differentiate between a established ischemic contracture and the infection causing subsequent contracture. So this is the a pattern of a short case presentation where you need to have a set of series of examination and arriving to a pattern of diagnosis and then differential diagnosis. Once you diagnose, the surgeon might ask, what do you do? Immediately, what we will think, we'll give for surgery, this surgery I will do, and this I will do surgery. So always be very, patient and cautious, in answering this question, what will you do? So always start with investigation. What investigation you want to do? So you have a patient with this ischemic contraction. You may not know whether they have a forearm fracture or whether they had any surgery for this forearm fractures, or they had any surgery for the distal radius, or they had any fractures associated with the supracondylar humerus, associated with any myositis, which is causing flexion contraction. So X-ray is vital. Ultrasound does has a role if you have localized contraction. For example, there's a localized contracture because of pseudo ischemic, pseudo Volkmann contraction, or scar or sinus. So ultrasound will definitely appreciate the involvement of localized muscle mass there and the involvement of nerve close to that. Blood test is not so significant, especially in this established contraction. Blood test obviously an investigating tool for a pre-anesthetic assessment. So the other aspect is that the surgeon will ask, what do you do? So we are coming to the treatment aspect. What is the treatment? What do you do? So to understand what you do, there are certain aspects which you need to understand. The deformity does not involve the forearm, but also involves the hand. So how much is the hand involvement, and what are the things which is, making us to plan such a way that you're going to treat, whether a contraction release, or a tendon lengthening, or a muscle style release, or a fusion. So these are things that are based upon not on the forearm aspect, on the hand aspect. So entirely the contracture has to be analyzed. So Zancoli has given a classification based on the intrinsic muscle involvement. He said if there's a mild deformity, simple claw hand, hyperextension at the MCP, and flexion at the IP joint. Paralytic intrinsics. The intrinsics are gone. So they have, in addition to the claw hand, the opponent's palsy, because both the median and the ulnar nerve is involved. In type 3, the intrinsics are not contracted, they are retracted. And the opposite of claw hand is happening, intrinsic plastic. And there's one more type, you have a combined deformity of all these things. So I was mentioning, there are certain things which, we need to put in mind before going into surgery. Surgeons are, should not be taken away with examining the deformity alone and prescribing the surgery. There are special tests which will help you to take you to that surgery. So this is one I've shown you previously. You reduce the claw hand, the patient can extend actively the IP joint. So your focus should be that the surgery should be done such a way that the MCP joint should be flexed, should not be extended. The other favorite question is that, look at this video, you will understand what is this. Here's a claw hand. So what I'm doing is putting a pressure over the dorsal aspect of the proximal phalanx. When I put a pressure over the dorsal aspect of the proximal phalanx, the deformity gets corrected. Watch closely. There's hyperextension at the MCP joint. I'm putting a pressure over the proximal phalanx. Means that I am manually causing the MCP joint to flex. While manually flexing the MCP joint, the extensor pull by the normal extensors, the extensor digitorum communis, they extend the fingers. When there is a claw hand or when there is ulnar nerve palsy, when you put dorsal pressure on the proximal phalanx, even though the intrinsics are paralyzed, even though the intraosseics are paralyzed, this extension is because of the long extensors which are coming here. So this test is more important. This is called as Bovier's test. Why Bovier's test? Because any surgery you are going to do for claw hand can also target MCP joint flexion, so that the long extensors will take care of extending the fingers. So for that, you need to have a good long extensors, the ADC of all the fingers. That's more important. So similarly, in this case, which has a severe contracture, where MCP joint flexion also has extension of the IP joint. So before jumping into the treatment, the anatomy aspect is very important. I was mentioning that the superficial compartment has the flexor digitorum superficialis, the FCR, the flexor carpi radialis, palmaris longus, pronator teres, and the FC tendon. The deeper compartment has the FDP muscle, flexor pollicis longus, pronator quadratus, and three interosseous nerve and artery. Similarly, the dorsal aspect of the forearm has mobile word, the brachioradialis, ECRL, and ECRB. The extensor compartment has the rest of the muscles. We also have Anconius compartment, which involves Anconius. Very difficult to diagnose or differentiate between Anconius in the compartment syndrome or sequelae. In the hand, we have 10 compartments. There's one multiple choice question. How many compartments are there in the hand? So we have 10 compartments. We do not need to release all those compartments in the hand, which I'll discuss in the subsequent slides. 10 compartments, but most common are the thenar compartment, the hypothenar, the adductor pollicis, this adductor compartment, and the interosseous. Dorsal interosseous these are the interosseous. Between the metacarpals are the dorsal interosseous. On the volar side, similarly between the metacarpals are the volar interosseous. They are separate, is separate. So we'll come back to the slide which determines what surgery we need to do. So a mild involve only a localized flexor digitorum profundus or ring or the middle finger. They may have a 1 or 2 contractions. Moderate, all the flexor digitorum profundus are involved, partial nerves are involved, severe, all the nerves are involved, and they have a claw hand deformity. Surgeons are very favorite because you need to have a theoretical exam also before coming to the practicals. So surgery wise, the classification is that a mild deformity, you can even go for a non-surgical treatment. You can passively stretch, put them on the splint, and then actually extend, put them in the night splint so that they will not have contractures. To start with, always have a non-surgical treatment for mild deformity. If the examiner asks, okay, the child, patient is not comfortable, you have put on the splint, what next? The other favorite question is that what next? What surgery you do? So the other surgery is that you can either lengthen the constantly tightened flexor muscles, or you can release the contracture which is adherent because of the ischemic contracture of the compartment of necrosis. You can release it distally. This is distally. You can release it distally so that this contraction will get released for mild deformity. Similarly, for the moderate deformity, in addition to these two surgeries, you can shorten the forearm. Why shorten the forearm? Because you shorten the forearm, the muscle which has a constant length will have added benefit, will have increased length because the forearm is shortened. This length is constant, this forearm is shortened, so the deformity gets reduced by itself. The basic principle behind it. The other aspect is that you can remove the proximal row. The scaphoid, the lunate, and the trichotillum can be removed here. You remove it, similarly you are reducing the size, the length of the entire upper limb, and this adds up to the constant length of this contraction exercise. So these are treatment modalities described in various literature and also in the books like Green's operative surgery, Green's operative hand surgery. For severe deformity, you have noticed that in a video where you flex the MCP joint, the deformity gets corrected and the IP joint gets the extension. So those are the surgical aspect where you should focus on tendon transfers, which can flex the MCP joint so that you will get the claw hand corrected and you can get a favorable or a fair hand function. So those are the tendon transfers which are available. If you have complete forearm lost because of the severe contracture, you can replace all those contracted, fibrosed, and non-functional muscle infarct mass, completely excise it, put a free function muscle here and suture to the flexor tendon to have the function. In addition to that, you can also do a nerve reconstruction. This is one video where what we have done for a patient, which we have shown in the recently in this presentation, had a severe contraction. When you have a severe contraction, you cannot operate. That's the basic principle. Why? Because the surgery, for any surgery or any tendon transfer surgery, the principle is that the joint should be supple. The joint is contracted, any amount of tendon transfer you're going to do is not going to move the joint. So this is the ideal principle in doing any tendon transfer surgery. And there are other principles, other list of requisite for doing tendon transfer surgery. The tendon should be, it should be, it should have been, it should function one, it should have one role, one tendon, one function. It can be easily salvageable, can be taken without any deficit, and it should cross one joint, one function. So those are the principles which are there in tendon transfer surgery. And beyond that, no contractions or no stiffness should be there for doing tendon transfer. So these are basic principles which help you in making your tendon transfer successful. So this child, the patient who had a severe contracture, we put them on the splint. Why? Because we want to reduce the contracture by passively or actively moving the joint. So here, the child did not have joint stiffness. They had contracture because of the muscle infarct, reduced the length of the flexor tendons, and not allowing the joints to move. What we are doing is a passively actively contracting and passively relaxing, so that you will get the constant length phenomenon, a little extendable, a little stretchable passively without any surgery, without any active intervention. So this is more important for all deformity, especially a mild deformity. This is the treatment of choice. Put them on splint, put them on passive contraction and extension with this flexor trigger splint, or for severe deformity, reduce the contraction, reduce the stiffness at the joint because of non-utilization or because of the deformity, because of the nerve causing paralysis of the muscles and subsequent deformity. So those are the non-intervention therapy which will cause the joints to flex and extend to a reasonable amount where you can do a tendon transfer to get back the remaining function or to get back a reasonable function. If a static splints are splint which are applied like this, will not allow any movement. So these are dynamic splints. Why dynamic? Because it allows movement. It allows movement, it allows flexion, and with the elasticity, it allows extension. So that this lengthens the whatever contractor muscles to get some function at the PIP and the MCP joint. We always like to have a static sprint. Static sprint is that it is always put there and it will not allow any movement. So static sprints are there to help put them or maintain this position at the night, and also to maintain the position for some time. Suppose they have one or two fingers contracted, you can extend them, put them in a sprint for some time, say 23 hours in a day. So that what happens, it stretches that particular contraction muscle. Non-intervention, it lengthens or stretches the flexor tendon to a certain limit where it will have, it serves the purpose of extending or relaxing the contracture, stretching without surgical intervention. So what do you define? Suppose the examiners might be interested. What will you see? Suppose if you are allowed to go into the theater, this patient comes to you for surgery, what will we expect from this patient? So these are the surgical steps which might help you to appreciate what we have been discussing clinically. So theoretically, what you have been discussing should be correlated to the clinical finding. Without that, you will not have any idea what we are going to speak. So this child, had a established Workman ischemic contracture. We say it's a moderate contracture because the nerve involvement was partial. The child did not have claw hand. They had both superficial and deep olar compartment. The extensor compartment is not involved. On exploration, we found that this is the ulnar nerve. So we completely decompressed, meaning that we completely neuralized the ulnar nerve from the surrounding adhesions and infarct muscle here. And we also did a neurolysis to the median nerve, where interestingly we found there's a difference between this muscle and this muscle. This is a normal muscle, and this is an infarcted muscle, pale looking, no active bleeding, adhere to the underlying tissues and underlying bone, causing the associated tendons. Whatever tendon passes through, whatever tendon is because of this muscle will go into contraction, will go into flexion. So this is we call as ellipsoid sort of contracture in the forearm because of the localized ischemic contracture or localized necrosis and muscle ischemia. So what we've also found that this superficial or the FTS, flexor superficialis, flexor digitorum superficialis, and these are the flexor digitorum profundus. So the flexor digitorum superficialis are looking normal. This is a normal looking muscle, but this was involving the deeper compartment. Deeper compartment are nothing but the FDP of all the fingers, FPL of the thumb. So what we found was that these are the muscles which are adherent or which are necrosed, infarct, become fibroblast. They start adhering to the underlying bone. This is the ulnar bone. Just attached to the bone. These are the muscles which do not attach to the ulna. They have a common attachment. We call it the common flexor origin, which originates from the middle supracondylar ridge, comes to the forearm, and then goes subsequently to the corresponding fingers. So they are attached to the ulna because of the compartment syndrome and the sequelae, which is causing adhesions and more contractions. So what we did was we excised this tendon and transferred to the flexor digitorum superficialis. This is what we could do. And in addition, we also excised the muscle infarct to get this function in this patient. Similarly, this girl, which we had shown her a severe contracture of this because of the severe Volkmann ischemic contracture. What we did is we did the extensor indicis properis to thumb, because this is thumb abduction is more important because this patient had both combined median and the ulnar nerve. So we need to have thumb abduction, which can be done by transferring the extensor indicis properis to thumb. In addition, we also found that the flexor muscles are completely damaged at the forearm, and we did not have active flexor muscles. So we need to completely excise the flexor muscles. To correct the claw hand, what we did is we harvested the fascia lata and divided this into 4 strips, and we transferred to the extensor carpi radialis. We call it brand transfers. This is to get the claw hand corrected. So what we do is we need to maintain the MCB into flexion. This can be done by having a tendon graft attached to the ECRL, active ECRL tendon, because the dorsal compartment was intact. So we took this as a donor and we passed through the volar to the metacarpophalangeal axis. Why volar? Because that only can cause, while contraction can cause flexion of the MCP joint. When it flexes, the IP joint becomes extended. So with this, through volar to the MCP joint, through volar to the MCP joint axis, it makes flexion of the MCP joint. Once the flexion of MCP occurs, automatically the fingers goes into extension. Because this girl had stiffness because of non-utilization or not using for a long time, we passively corrected with therapeutic splint preoperatively and made the joint supple. Once the joint is supple, you need to attach to the extensor expansion. So you need to take through small incision to on the ulnar side of the index finger and on the radial side of the ring and the little finger, something like this, so that the claw hand deformity just gets corrected. So in addition to that, we did the extensor indicis properis for the thumb abduction to get the thumb abducted, and the ulnar nerve was completely adhered to the fibrosis. We excised it, and then we put a cabled sural nerve graft to have a sensory, to get back the sensation in the ulnar aspect of the hand. So this was the final movement we got in this patient. And this was the follow-up movement where the child, the claw hand is also getting corrected with this therapeutic splints. So the other most common surgery, which is always asked by the examiners, are what is a muscle sliding surgery or what is a max page surgery. So this max page or muscle sliding surgery is nothing but the forearm, the common flexor origin, which contains the FDP muscle, the pronation muscle, which are attached to the middle supracondylar ridge, attached to the ulna. Everything is completely, taken away, completely erased from the middle supracondylar, completely erased from the ulnar nerve, so that it just slides distally. When it slides distally, the contracture here just gets automatically corrected. When it just slides distally, the deformity gets corrected. These are surgeries which are preferred for mild deformity or a moderate deformity, where you have a localized muscle infarct causing the contraction. So this is one patient where we did a muscle sliding surgery, preoperative finding. The intraoperative finding, we completely released the muscle to get this extension. Wrist should be completely extended, finger should be completely extended to get this function. Severe contraction with large infarct, the option is the free functioning gracilis transfer. We take the gracilis along with the vessel and the nerve, and we take it and put it in the forearm, and we anastomose either to the radial artery or to the anterior intraosseous artery, and the nerve, whether we repair to the median nerve or the branches of the median nerve, it is functioning in the proximal. So this is the one of the treatment aspect for a severe contraction with a large infarcts. The other aspect is that surgeons are very, the examiners are very focused towards surgery advantage and disadvantage. If you say fractional lengthening, surgeons, the examiners will ask, what are the disadvantages of fractional lengthening? So if you're going to see, this is a tendon. If you're going to lengthen the tendon by doing a fractional lengthening or exoplasty, advantage is that the contracture gets released. Disadvantage is that the active flexion which is there gets lost because of the lengthening of the flexor muscle, and more of disruption of the muscle resting length. What is resting length and loss of flexion? The resting length is that, see, when you flex, these are the muscles, flexor muscles are in maximum contraction. They are in maximum contraction. On the contrary, the extensor muscles are in the maximum relaxation. Similarly, when you extend, the opposite happens. So this is called as a resting length. Resting length is a phenomenon where when you contract or when you extend, the muscle length extends or goes, widens, or it just has elasticity to a certain extent where it can give its full contraction. Beyond that, cannot contract. Beyond that, it loses the contraction. That's why when you lengthen a tendon, which is a constant length, apparently the deformity gets corrected, but the muscle cannot contract because the length is increased, which a muscle cannot contract. So muscle can only have elasticity or can only expand or can only lengthen to a certain maximum length where it can extend its full strength. Beyond that, it cannot extend, or beyond that, cannot contract. Similarly, the contraction, when it contract, this has to contract to the maximum. There is a resting length. There is a maximum resting length happening in the flexor aspect. There is a maximum relaxing length happening on the extensor aspect. When you extend, opposite takes place. So these are the things which you lose when you do a fractional lengthening or exoplasty in the flexor tendon. The other aspect is that if you slide entire flexor origin distally, the deformity gets corrected. What are the disadvantage? When you erase this muscle from the elbow, you should avoid injury to the stabilizer, medial stabilizing ligament there. You should avoid injury to the common intraosseous artery here. When you do, there's always a possibility it can damage the anterior intraosseous nerve or the posterior intraosseous, the anterior intraosseous nerve, the anterior intraosseous artery, which are all branches of the median nerve. So these are the associated injuries which can happen when you do a distal slide procedure. The free functioning muscle transfer is one of the best options for severe contracture. The disadvantage is that it needs a learning curve. It needs a microsurgical team. So with this, probably we can have a lot of questions and interaction, so that that will be more, way of getting the information shared and getting, uh, way of communicating with the postgraduates. So I think we will have a lot of questions based on the talk. With this a small, presentation about workman ischemic contracture, you will have a lot of questions which can be answered through questions. So I think Dr. Ramesh can coordinate with the questions, and we can go ahead with the questions.
Thank you, Terrence. It was an excellent presentation. You cover all the facts of workman ischemic contracture, how to examine, how to make a diagnosis. The treatment protocol depends upon the severity. Uh, VAC is a difficult case, not only the postgraduate, even treating orthopedic surgeon. You teach it in a easy way. One thing I want to add, postgraduate should always, VAC most commonly seen in following supracondylar fracture. So you always examine elbow joint and wrist joint. Some of the PGs are some questions I'll ask you. Is there any specific time duration for which splinting should be done? Unmute, Terrence, unmute yourself.
Sorry. The splinting are only a temporary or transient way of treating this patient. They are a non-surgical intervention modality, meaning to say that it has its own answer in it. A milder deformity can be treated with a splint. How long? The splint can only function in an elbow or in a wrist. More than 3 weeks in an elbow will cause stiffness, practically speaking, and more than 6 weeks in the wrist will have additional burden of causing more stiffness. So ideally, 3 to 6 weeks is the duration. This has the answer in it. If you're putting an above elbow splint, 3 weeks is a maximum time, because stiffness to the joint cannot be compensated to have this deformity corrected, which obviously is a non-intervention and non-surgical modality. In the wrist, 6 weeks is the maximum duration by which the deformity should be passively stretched or passively extended. If not, surgery can be done to have this function. If you're using a dynamic splint, dynamic splints are splints where movement is possible. So you need not worry about the stiffness. If you have a movement happening at the, at the fingers or at the MCP joint, it's as well as good. As long as it is, say, around by 6 to 8 weeks, if you could get the movement full, then probably you can take that splint and then plan for any tendon transfers where you can get the other functions. Dynamic splints can be made for 6 to 8 weeks, provided you get the movements going. You get the movement which you want. So you don't need to worry about stiffness, because the fingers are moving with the elastic, the what you call the rubber bands which are put on the volar side. So you need not worry about the stiffness. Static splints, I don't go. We don't advise more than 3 weeks for the elbow, 6 weeks for the wrist.
Good, Terrence. Another question: can orthodesis be done along with the tendon transfers?
Yeah, very, very good question. Orthodesis is one of the treatment options. Orthodesis is one of the treatment option. Why? Because you save one joint, you have more tendon to transfer. Suppose if you do orthodesis of the wrist, for example, say orthodesis of the wrist, you have the wrist extensor, which can be transferred for a finger flexion. Say ECRL can be transferred to the finger flexion, can be transferred to the FDP. FDP flexes the IP joint of the fingers. Disadvantage: see, for any hand to function, you need to have the tenodesis effect. I'll tell you, when you flex the wrist, fingers go into extension. When you extend, the fingers go into flexion. If you need to hold an object, hold the object, watch me, the wrist goes into dorsiflexion, and then you have the good grip. So for any good grip, the wrist has to be in dorsiflexion. And you need to have, you lose the tenodesis effect when you fuse the wrist. In addition to that, once the tenodesis is lost, the amount of function you're going to get with the wrist arthrodesis compared to a tenodesis effect needs to be balanced. The advantage of fusion in fingers is good if you have severe contraction of the PIP joint. PIP joint severe contraction means the joint cannot be flexed or cannot be extended, can be fused to a functional position, say around 30 degree of the index finger, add 10 degrees to the other fingers, 10 to 15 degrees to the other fingers, 30, 40, 50, 60. So it comes to a functional position. You can do this if you only get the MCP going to flexion. If you get the MCP flexed, this is a good functional position for arthrodesis in severe contraction, not for the mild deformity or not for the moderate deformity, where this tenodesis effect is very essential for any movement or any hand grip or any function. The other aspect is that can you take the proximal row carpectomy, or can you do additional removal of this bone in the wrist? You can do, because they also provide movement. They are not fusion. A better variety of fusion is you can do a proximal row carpectomy. The other concern is that you remove the bone, you always shorten the forearm so that the constant length on the volar side, the volar muscles gets advantage because you can extend it. So proximal row carpectomy is one of the treatment options for severe contracture. Instead of fusion, you get this tenodesis effect. So I think I've addressed that issue, arthrodesis issue.
Good, very good explanation. Another question, when to surgically intervene? Suppose in case of, my doubt is mild case, you're doing physiotherapy, when to intervene surgically?
Yep. I'll summarize all my presentation. I'll summarize so that it will answer the question. Mild deformity, you know that particular muscle are involved. Say the FDP of the long in the middle finger or the ring finger is involved. You put them on passive stretching and put them on splints for 6 weeks. If you could get that improvement, it's well and good. You maintain them in the morning hours without splint and in the night splint. So you take care of the stiffness and also you take care of maintaining the correct position. 6 weeks is a rough time where you can decide whether this intervention is working or not. This intervention is not working, probably surgical release, either a fractional lengthening or a release, a partial max phase release, where you can just release that portion of the flexor origin so that it slides distal and you can get the deformity character. Do not leave it alone, because you need to protect them. This has to be put on splint for 6 weeks and then start your therapy. So this is more vital than releasing surgery. For moderate surgery, if you're planning to do a fractional lengthening and max page, the same principle remains. In addition to that, if you want to do a tendon transfer, what we did is we always got the distal joints functioning, because you do any number of tendon transfer in a stiff IP joint, it's not going to function. So I can put them in a dynamic, we call as flexor outrigger sprint. If it is in the flexion on the flexor side, on the volar side, it is called flexor outrigger sprint. On the dorsal side, we call as extensor outrigger sprint. What is outrigger sprint? On the flexor, it is flexor. Outrigger is something out. Okay, something out. What trigger? Trigger is triggering the movement, triggering the flexion movement. It's called as flexor outrigger sprint. So everything is in the name. So it obviously has self-explanatory. So similarly, you put them on some flexor outrigger sprint for 6 weeks up to 8 weeks. See how we can get the movement of the IP joint, because they are not stiff. Joints are not stiff. They are because of the contracture. Because of the contracture here, because of the pull, they are in this position. Because they are constantly this position, the associated ligaments, they adapt. What are the other associated ligaments or the structures which adapt to that? On the volar side, we have the volar plate. Volar plate contracts. If the volar plate contracts, it again contracts, flexes the PAP joint. On the dorsal side, what happens? Once it contracts on the dorsal side, the central slip remains there, but the lateral slip, it tends to sublux it. Tends to sublux polarly, causing a Botner deformity. So these are the compensatory deformity which is happening because of associated with this contracture deformity. So this has to be taken care. Whether if you could passively or put a dynamic splint to get this movements happening, provided this outrigger splint is such a way put, it allows MCP to go into flexion, thereby it corrects the deformity whichever happens in moderate or severe deformity. So it corrects the deformity at the same time allows the finger to flex at the PIP and IP joint. So this has to be taken care. So for very severe contractions, where you could not get any movement despite putting them on the splint, probably fusion is one thing which you can decide by 6 to 8 weeks of treatment. Fusion of fingers at the PIP joint, and you can plan for proximal rocarpectomy or a fusion, provided you are ready to lose the tenodesis effect of the wrist, which is more important for function. So I think I've answered the question for mild, moderate, and severe.
Good. Excellent explanation. I have the basic question. Is the tendon lengthening main principles of treating VIC? Because already the hand is paralyzed. The further lengthening will weaken the strength of the grip or something.
It's very true. You're right. You're always right. Because tendon lengthening is not the surgery which is indicated for workman's contraction. It is a surgery which we routinely do for paralytic contractures, localized paralytic contractures. Say for example, a poliomyelitis with a equinus foot, we do a tendoachilles lengthening, provided the child or patient should have a normal quadriceps and the normal associated muscles in the foot. Similarly, those deformities, localized deformities, or localized contractures can be successfully treated with fractional lengthening. So the same principle holds for the workman's contraction. They're only indicated for a specific muscle infarct. So suppose they have only FDS or FDP of middle finger, then a fractional lengthening will help. Otherwise, they will weaken the hand grip. They will weaken the functioning of the rest of the flexor. It's true. Why it is being been propagated in all textbooks is because they have a specific and a limited role only for a localized and a mild variety, not for moderate or not for severe cases. In a long term, in a long run, fractional lengthening always weakens the hand. One of the contraindication, one of the side complications of fractional lengthening.
When the child grow, the deformity will progress. How will you address?
That is a very challenging question. The bones are normal. They have the normal facial end, so the bones will grow. The deformity is constant because the muscle cannot, the infarcted muscle or a necrotic muscle or a dead muscle cannot allow any growth or cannot allow any expansion. So the deformity will progress. Deformity will progress. And why there is shortening? Deformity progresses. Whenever there is any action, whenever there is any movement, there only the growth happens. This is a basic phenomenon. A disused limb and a used limb is always different. For a lower limb, you need to have a weight bearing to promote growth, to promote activity, to promote lengthening, to promote normal growth of muscles and normal growth of bone. Similarly, for the upper limb, movement is very essential to allow the bone to grow, the physis to grow, and the muscle to balance. That's the reason for shortening. And since the muscle cannot expand, cannot have the normal, the resting length, because of constant contraction, the deformity will worsen. Deformity will gradually worsen over a period of time. The child grows. That's the reason where the surgery has to be at the earliest in the younger group to get good functional result. We have been seeing 2-3 patients in our follow-up where they come at the age of 11 to 12 or 13 years, where the deformity has been established with obvious shortening between both the upper limbs, marked wasting with a fixed contracture at the wrist and also the fingers. So contracture will worsen over a period of time. The child is not operated at the right time.
Okay, good. Any questions from postgraduate? Okay. This type of short case, within the short duration, very difficult to examine all aspects from elbow joint examinations, muscle examinations, and nerve examination. Can you tell me any tips for short examination of nerve examination? In simple way of examination of all nerves.
Yeah,
It's a very short duration of a short case.
I understand. See, if during our postgraduate time, we only get to say the diagnosis of a short case. We did not get time to examine, even though we examined properly and then we tried writing everything. By the time we go to the examiner, they'll ask only what is the diagnosis.
What is the diagnosis? Most of the time, the examiner asks this: what is your diagnosis? How to arrive at a diagnosis? Then tell me.
Why this is being more emphasized is that there is no shortcut to clinic examination. This is what we have been taught, and this is what every teacher also tries to teach. There's no shortcut to examination. The candidate will not be failed if they don't know the treatment aspect. But candidates are liable to fail if they don't know the proper way of examination. Because examination is only to know how much you are really put your clinical knowledge and clinical acumen. Surgical aspect, nobody can fail you because you are a postgraduate, and definitely you can learn while you become a consultant, whatever it is. So, yeah, in a short case, very difficult to bypass certain clinical examination. If you're ready pre-surgery, as we are getting ourselves ready for pre-examination, if you're ready pre-examination wise, all those things should flow like in a protocol in a coordinated way. By looking the patient in the far, it should be in your mind. Okay, inspection, I should see shortening. Okay, length, I should measure the length. The deformity, I know the attitude. There's a contraction at the wrist, fingers are okay. I need to examine them, look for the angle, look for the nerve. Classical is that thumb extension is the radial nerve. We call as this O sign for the ulnar nerve. And similarly, for the ulnar nerve, they used to ask abduction and adduction, or if not possible, they will ask the middle finger to lift and extend the abduct and adduct. So these are simple examination for these three nerves to quickly come to this. But these patients will not have this finding. They are not isolated nerve palsy. They are a combination of nerve palsy. Most commonly, they are combined median and ulnar nerve, where they will have combined nerve palsy. It's very difficult to isolate and say, okay, only ulnar is involved, only median is involved. So all they need is that what type of contracture are you going to present to the examiner? If you could start right from the presentation, clinical examination, that if you could give an impression that, okay, this candidate is dealing with a severe contracture. Okay. Then if a severe contracture, okay, what is going to tell us and how he's going to convince us this is severe contracture. So there comes the role of examination of the contractures. Contracture and the deformity measurement is more important. How much degree of contracture is there? When there is a pronation contracture, why supination is not possible? So these are the questions which should be keeping, the examiners keep asking you. They can always ask you some pulling questions. What is the range of supination in this patient? Because this patient always has a pronation contraction. It's not possible to have supination. So these are the triggering questions leading questions which might ask you to make you out of an examination mood. So there are certain aspects which you should obviously look into and say, okay, this is a case of severe contracture, and what are things I'm going to present so that the examiner get convinced. Contracture angle, deformity measurements, range of movement, active and passive. In finally, sensory examination is very essential. You should have all the kit with you, even though examiner doesn't want to look into, but you should be in a position to show how you diagnosed localization, how you diagnosed 2-point discrimination, how you diagnosed touch, deep pressure. So these are things which has to be in a kit when you're going for examination. Very difficult case, very difficult for a short case in a short span of time. It should be like all these diagnosis should be, the clinical examination should be, going through your mind entire time, and whatever questions they are going to ask, you should be ready to say. Most of the time you will end up in diagnosis. What is the diagnosis? And most of the time you should be in a position to say why your diagnosis is such a way. If you have give a good clinical, good, the diagnosis, say a case of a girl with this contracture, with shortening, with this classification of a moderate or severe contracture, with a neurological deficit and with shortening, examiners are happy to say, okay, you have examined them and you have come to a conclusion what treatment option you are going to do.
But I hope it is very useful to postgraduate. Any other questions from postgraduate? I think no more questions. Okay.
The one question, like, please elaborate complex regional pain syndrome.
Complex regional pain syndrome. Yeah.
Complex regional pain syndrome is entirely different entity. We don't, mix we call CRPS with the forearm, the compartment syndrome is a different entity. It's something like a simple sympathetic overactivity, which is causing the associated effects of sympathetic effects because of any precipitating injury. It can be a fracture, it can be a burns, it can be compartment. Anything which triggers the sympathetic activity will have the associated deformity. What we have been discussing in the International Hand Surgery Society Forum is that there is no term called as complex regional pain syndrome. So postgraduates, please do not, get into all these controversies. As far as you have been given a topic of CRPS, get through the knowledge of CRPS, whatever the textbook says. We, the International Hand Surgery Society, we have two classifications, CRPS 1 and CRPS 2. CRPS 1 is obsolete. Obsolete means that most of the hand surgeons, they don't believe that there is a term called CRPS. Such a controversy topic is this. It's good that you have taken it. Once you become a consultant, you will know what exactly is it. For anything to happen, there should be a reason. For anything to happen, there should be a reason. So any injury which is causing associated sympathetic activity, wasting, shining of the skin, nail changes, and stiffness, there should be something, a reason to it. Complex regional pain syndrome, or syndrome, which is defined as etiology of symptoms which cannot be explained. What are the things which cannot be explained is put as CRPS, meaning to say that it is a diagnosis of exclusion. If you have a fever of unknown origin, how can you treat? So we ourselves refer this entity as a fever of unknown origin. There was an entity called fever of unknown origin. So we used to treat them with all available drugs. No, nowadays in the current medicine, trends where we have a lot of updates and scientific rationale, we cannot have a diagnosis of exclusion. CRPS is a diagnosis of exclusion. So we will have a discussion if you really are interested in CRPS. Obviously, for examining going students, I don't think CRPS is of much value right now. We'll have a brief discussion on CRPS some other day, but do not get confused with CRPS. CRPS has a lot of controversy. It's a diagnosis of exclusion. To have you people understand what is CRPS, I'll tell you small mnemonic. CRPS has a CRPS. CRPS has continuous pain. C for continuous pain. These patients, they'll have continuous pain. And P is always, all placebos, all treatment, all diagnosis because of pain, they have various classifications are based on P. CR. R is the reflex. Because of this reflex sympathy, there is no reason to diagnose this entity. There is no reason. You have to rule out all other possibilities. C is a continuous pain, or rule out other possibilities before putting diagnosis. P, lot of placebos, a lot of treatments are being there, right from steroids to stellate ganglion bug. And S, S is something with the sympathetic effects, like the wasting, redness, lot of perspiration in the upper limb. So all these things have been put as entity of CRP. CRP is a different topic. So we'll have some other day to discuss about CRPs.
Okay. One more
Yeah.
question. Because anterior introsus artery is an end artery, the flexor compartment is commonly affected, or any other reason, sir?
We don't say anterior introsus artery is an end artery. For postgraduates like you, the end arteries are the distal arteries. That should be the basic understanding, because anterior introsus artery can communicate with the posterior introsus artery. Anterior introsus artery can communicate with the posterior introsus artery through the introsus compartment. So it's not an end artery. We have been doing a lot of flaps based on the anterior introsus artery. We have taken a complete forearm, the skin with the artery, and been used to traverse to reverse to the as a pedicle to it. So the reason for involvement of flexor compartment muscle is very simple. As Holden in 1979 and 75 said that there can be only two reasons for compartment syndrome. One, injury at the vessel level. Say if you have brachial artery injury, brachial artery thrombosis, there is a ischemia because of brachial artery. Subsequently, the collaterals can survive to a certain extent where it cannot meet up the demand of the muscles which are there in the forearms. Subsequently, they develop compartment syndrome because of ischemia and necrosis. The other reason is that a direct injury to the forearm, direct injury here, high pressure direct injury, can increase the intra compartment, can increase the osteofacial compartment pressure, meaning say that the compartment around the muscles and the compartment which are surrounded by the muscles over the bones are increased, so that the compartment syndrome happens. So that is because of a local and vicious circle which is happening. Reduced blood supply, so venous stasis, increases more pressure in the compartment. Tissues, they don't get enough perfusion, they die. So you need to measure the compartment syndrome. Say 40, more than 40 is always very dangerous. Why 40? Why that number? For any tissue to get perfusion, the pressure is 30 millimeters, the pressure for a tissue perfusion. So the capillary level perfusion is 30 millimeter mercury. If anything goes more than that, the capillary perfusion will not be there. There won't be any blood supply to the muscle. There won't be any blood supply to the corresponding water bones there. So automatically they go into ischemia and necrosis. That's why you call us more than 40 millimeter mercury is a compartment pressure where you need to operate. So basic understanding is that a localized vicious circle which reduces blood supply because of injury or because of direct impact to that muscle, reduce blood supply, increase venous stasis, again more pressure to the compartment, reducing the perfusion pressure, no blood supply to the muscle will cause ischemia. Why flexor compartment? Because the injury is happening in the most common injury is happening in the supracondylar humerus involving brachial artery, or direct injury to the forearm, especially when you have any associated high energy injury. That's the reason where directly the forearm muscles are involved. Why extensor muscles are not involved? The injury which is happening in supracondylar fractures, brachial artery are most commonly involved, and brachial artery, the extensor compartment muscles, they have a separate supply through the brachial artery, which is given here, profunda brachial artery. They have a lateral forearm muscles, the arteries, they also supply the lateral forearm. And they also have intraosseous arteries, which also supply the extensor aspect, which are all not a part of brachial artery. So why forearm muscles? I think this is the reason why the forearm muscles are involved, and that too not superficial. The first muscle to involve are the deeper muscles. The FDP of the long and the ring fingers are more commonly involved. Anterior intraosseous artery, I don't say it's the end artery because they have a communication with posterior intraosseous artery. There is a communication there, and many occasions where even any radial artery or ulnar artery is damaged, these intraosseous artery, they play a very vital role in maintaining the circulation in the forearm.
Good, Terrence. I think you covered all the question and answer which may ask examiner in the examination, particularly in workman ischemic contracture. Dr. Thadapan sir, you want to say something, sir?
Yes, sir.
Good evening, sir.
Good evening, sir. So it's a wonderful coverage, sir. You have covered everything as usual. Enjoyed the last.
Thank you, sir.
It's a very interesting topic, sir. The attendance is very meager. I don't know why. Because you have covered everything, sir. You have covered everything from clinical examination to treatment aspect. I have one question, sir. In the mild cases, in mild VIC, in clinical scenario, how will you differentiate between a dependence contracture, ulnar Clahan, and VIC? Stage 1.
Very valid questions. A very good question. Dependent contraction are a localized fibroblastic proliferation, which commonly involves the ring on the little finger. The involvement is very classical. They are nodules felt in the palm, especially on the ring finger and the little finger. And they don't have any history of precipitating events, trauma or artery injury subsequent to that. Ulnar palsy, you are correct, sir. Ulnar palsy can mimic a localized contracture of the FDP of ring and the little finger. The motor examination and the sensory examinations are vital because it's very difficult to diagnose ulnar palsy, especially low ulnar palsy. The other aspect is that you can have intraosseous wasting and you can have all signs positive for ulnar palsy. These are the one which classically differentiates between ulnar palsy and the localized muscle infarct, especially involving the long flexor digitorum profundus of ring on the little finger. In addition to that, sensory loss, classically high ulnar palsy will also have a sensory loss on the dorsal aspect of the forearm because of the dorsal ulnar branch. If it's a low ulnar palsy, the sensory loss is very classical. I've shown the picture, involvement of the ulnar, the little finger and the ulnar half of the ring finger. So this also differentiates a localized ischemic contracture involving ring and the little finger with low ulnar palsy. In addition to that, ulnar palsy can be because of post-traumatic or can be because of injury, which can have a cut injury at the wrist or cut injury at the elbow level. So any cut injury or any injury which is inciting can be helpful in eliciting injury. Also, in post-Hansen's deformity, where deformity can be bilateral, where the ulnar can be thickened, where they also have associated features of burnt out cases of leprosy, can also differentiate between a localized compartment syndrome involving these two muscles and the ulnar palsy. The other common inciting factors are very rare presentation or ulnar artery thrombosis causing localized ulnar palsy or associated with Guyon's canal. These are the differentiated diagnosis where Guyon's canal also can have ulnar palsy, but the sensation is intact in Guyon's canal because of the involvement of the motor aspect of the ulnar. So most common things I have covered, differentiating between ulnar palsy, low ulnar palsy, and high ulnar palsy.
And this Workman sign is exclusively positive in only in VIC. This Workman sign.
It is exclusively, yeah, you are right. It's exclusively positive in VIC because of the fixed construction and the constant length of the flexor muscle.
Okay, sir. Shall we wind up, sir? I think we have covered everything. You answered almost all the questions.
Yes, sir.
One more question you have not answered. The first question. It was a question: can we get a picture in lower limb similar to upper limb, instead of VIC in lower limb? Is there which compartment muscles is commonly affected? Dr. Mani has asked this question.
Yeah, the compartment syndrome in the lower limb presentation is completely different from the compartment syndrome present and involvement in the upper limb. The most commonly involved compartment in the lower limb are the superficial and the lateral compartment, which is supplied by the common peroneal nerve. In all those compartment which is causing, the posterior tibial nerve is the least which is infected. I mean, which is least affected. So the compartment syndrome of upper limb is quite different from lower limb, but the presentation, the clinical presentation, the pathophysiology remains the same. The compartment syndrome involving the nerve and the subsequent muscle will cause the deformity. In the upper limb, the volar compartment are most commonly involved. Subsequently, you will have flexion contraction and pronation contraction. In the lower limb, the superficial and the lateral compartment are involved, where you have a foot drop, and you will have an inversion deformity because of the loss of evertus and the ankle evertus and the ankle dorsiflexus. Tibial nerve is least affected in lower limb compartment, where you have you may also have severe contracture where you can have long toe flexors are involved. But I have not seen long toe flexors involved. But common involvement is the common peroneal nerve. It's very sensitive to ischemia, very sensitive to injury, very sensitive to ischemia more than 4 hours. So superficial and the lateral compartment are more commonly involved. They will present as a foot drop. They will have a lot of sensory loss in the superficial and the lateral compartment supplied by the peroneal nerve. They won't have a toe dorsiflexus. They'll have weak EHL. So something like a wrist drop, something like a foot drop, they have a presentation in associated with contracture of the lateral compartment and cervical compartment.
Thank you, sir. Thank you so much. I think most of them will be viewing this in YouTube.
Yes.
Later date. Shall we wind up, sir?
Yes, sir. If you don't have any questions, we can wind up.
No more questions. Ramesh, sir? Ramesh Prabhu, sir?
Yes, sir. No more questions. We can wind up, sir.
Thank you so much, sir. Terrence, sir, it's a pleasure listening to your lecture. We learned a lot. I also thank Dr. Ramesh, sir, for
Welcome, sir.
We thank the postgraduates who patiently heard the lecture for the past 1.5 hours to 2 hours. I also thank our president and secretary for giving us this opportunity, as well as the Olympic team, Ramesh, and his colleague, Tesh. Thank you all. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Good night, sir.
Thank you. Thank you, sir. Thank you very much.